Hi, I'm Jack Cush, Executive Editor of RheumNow.com. It's July the 1st, Friday, and this is the RheumNow Week in Review. A lot of interesting information in the last week on the website from the social media feed of just a few. One we posted today I thought was very interesting, and that is monitoring patients with gout and their serum uric acid levels. We all know the target is 6 and less. What if you were actually to give that task to other personnel and not rely on patient visits to achieve that goal? We do know there's a lot of evidence saying that patients don't achieve that goal, and that we don't usually use doses much higher than 300 milligrams per day of allopurinol. So in this one study, they actually looked at whether you could assign this to pharmacists, and there were two interventions groups. There was a non-intervention group and a pharmacist intervention group, where they pharmacists monitored the uric acid levels and adjusted the dose of allopurinol, and they found threefold higher rates of success being achieving a uric acid of less than 6.0 in the pharmacist-led monitoring group. Maybe a model for how to best manage gout going forward. An interesting secondary study from the DUO study. This is a study of digital ulcers in patients with scleroderma. They looked at the predictors for gangrene, a certainly unwanted outcome. And they found that if you were a former or current smoker, if you had 3 or more finger digital ulcers, prior history of gangrene, or sympathectomy, that you were at substantially higher risk for gangrene overall. Some of the news items that were on the website include one from yesterday, which was on checkpoint inhibitors. This includes drugs such as ipilimumab and nivolumab, which are two new checkpoint inhibitors that are being used to treat difficult cancers like melanoma and whatnot. This is a report from Johns Hopkins where they described 13 patients who have inflammatory arthritis, and 4 of whom also had Zika symptoms and Sjogren's syndrome. Some of these patients look like they have RA-like arthritis, and some just more of a oligoarticular process, but they're highly inflammatory. It is chronic, and it is a growing list of autoimmune features that have been associated with the use of these new checkpoint inhibitors. A review of tocilizumab was also published recently. As you know, tocilizumab is a category C drug for which there hasn't been a lot of data in the literature about the safety of tocilizumab at the time of conception, and this report details data taken from the medical literature and the Roche Global Safety Database, wherein they found 288 pregnancies where the mother was exposed to tocilizumab at the time of conception or during the pregnancy. The outcomes of those patients were known. 61% live births, 22% spontaneous abortions, 1 stillbirth, 4.5% malformation rate, and a higher than expected number of preterm births at 31%. The malformation rate is about the population rate, 3 to 6%, and there certainly is no controlled data. So for a drug that generally you wouldn't recommend, this is growing data that we need more study on, but this is encouraging information about the potential use of this in women who wish to get pregnant. Cancer risk was looked at by a recent Taiwanese study that looked at over 20,000 patients in Taiwan, a quarter of whom were on biologics and the rest were on non-biologic DMARDs, and they looked at the occurrence of cancer over a long period of time, and they found that cancer rates were actually higher in the DMARD group than in the TNF inhibitor group, suggesting that there may be as much as a 37% reduction in cancers, and that's all cancers, in those who took TNF inhibitors. However, when they looked specifically at hematologic cancers, there was a non-significant but trend towards more hematologic malignancies in the TNF inhibitor treated group, with an SIR, which is a standardized incidence ratio, sort of like a relative risk, of 4.6 for TNF inhibitors and 2.3 for DMARD. So more data needed, but that's encouraging either way as far as cancer. Fatigue has been a subject that we often struggle with, and something that's not often talked about. And we know that our patients who have fatigue will get better when we control their inflammation and their rheumatoid arthritis. But what happens when you give patients with fatigue a biologic? So the Cochrane database actually examined this, looking at a large number of trials, and they found that biologic interventions, not surprisingly, will reduce the amount of fatigue in patients with active RA. The reductions are quite modest, but nonetheless are expected. So this was done by a group in England. Another group in England also published another paper that looked at what happens to patients in the BSRBR, the British Biologics Registry in Great Britain, and they found that of patients who achieve remission clinically, not all of them actually achieve remission as far as their fatigue, suggesting that sometimes fatigue needs more specific treatment than just the arthritis and anti-inflammatory treatment alone. So, and generally I would assume that means treating the other things that give you significant fatigue when you have arthritis: depression, chronic pain, poor sleep, metabolic disorders, etc. Lastly, there was an important study of hyperuricemia and its effect on outcomes. They specifically looked at patients who were hypertensive, who had hyperuricemia, and sought to identify the associations. And they showed that having hyperuricemia increased the risk of cardiovascular disease 51%, increased the risk of all-cause mortality 12%, and increased the risk of diabetes also substantially, as much as 80%. And then actually there's one more about family history. I think that's something that we all struggle with. Generally, two different reviews from the Karolinska Institute come away with the following: that number one, family history, while it does increase the risk of incident RA and may have an association with seropositivity, doesn't influence clinical outcomes in the long run, nor responses to therapies, and that's good to know. We do know that as far as the risk of developing RA in a first-degree relative, the risk there is about a threefold risk in a first-degree relative. The risk of getting RA in an identical twin ranges from 12 to 15% concordance rates if you're a monozygotic twin, and less than 4 or 5% if you're a dizygotic twin. So again, the influence of genetics and family history may not be as large as most people think. That's it for this week. If you want these citations and links, go to the website where you can find them under the video tab. Be sure to follow Rheumatology on RheumNow.com. Next week we'll be on vacation, but we'll be running some very good articles, and keep up with the Twitter account as well. See you soon.